All right, good morning. Thank you to everybody who is joining us for the lower extremity deformity and non-union course. The chairs of the course are myself and Michael Sirkin. And so why are you here? Well, most of us do see patients that come in with difficulties after fractures, or maybe they have congenital deformities. But this is a 48-year-old avid cyclist who had type 3B open pilon fracture that was fixed 15 months ago, that was referred. I got it, sorry. Who couldn't put his left shoe into his bike clip, so he kept having problems with riding his bike. So on physical exam, he had this deformity in the prone position, and you can see that on the left side, he has external tibial torsion of about 15 degrees more than the right. So he underwent a rotational tibia and fibular osteotomy, and this is what he looked like before his splint went on. And so just by doing that rotational correction, I was able to match his other side. And this is what he looked like at 7 months after the osteotomy, and he was able to ride his bike and he'd healed his osteotomies. So the outcomes for this, learning outcomes for this course are to identify how to correctly evaluate lower extremity deformity and non-union, list the indications for lower extremity deformity correction, and perform these techniques, which this will be more, I'll explain that later as far as a live event down the road, to restore extra-articular alignment, utilize operative techniques for intra-articular osteotomies, and recognize strategies for leg lengthening and bone transport, mostly as it relates to non-unions. But this course was inspired by relationships that most of the faculty have had in the past with Dr. Mast, who unfortunately passed away this summer. And there used to be a course that a lot of the faculty had been involved with, either as faculty or participants, that was called the Solutions course. And a huge component of that course was deformity evaluation and osteotomies. And so we all were affected by Dr. Mast and learned a lot from him. And so that's what inspired us to start this course. He was a great planner. And as you can see by a drawing that he just did, you know, impromptu in the OR, he was an amazing artist as well, both on paper as well as surgically. So this particular course plan is that this is going to happen over 10 Saturdays. So this is the first one, obviously, and it'll start at 11 a.m. Eastern. It'll be a live online event, and this is being recorded, and this will be available for viewing after, about 24 hours after. You'll receive a link, and it'll be available on the AO Trauma North America YouTube channel. There will also be a 60-minute session on Thursday, so there'll be 9 of those. That'll take place at 8 p.m. Eastern, and it's labeled Ask the Expert session. And after each event on Saturday, some of them will have homework that you'll have to kind of get done during the week, and we'll check on that Thursday meeting, as well as after discussion group weeks, you'll be able to submit your own cases that we can go over during that time. Primarily, it's for participants that are either viewing this event live or that do it after the event to make sure they get all their questions answered. And it allows you time to catch up if you miss the online live event. And then eventually, when obviously everybody's been affected by the pandemic in multiple different ways, and so the live event will be scheduled later this fall in Las Vegas to be able to do the intended practical exercises that included performing osteotomies on cadavers, which is pretty unique. And so this slide of great looking people are your faculty, and every one of them will be presenting over the course of this time. And then if you're able to attend the live event, they'll be there to help you work through those exercises as well. So take advantage. This is you know, all of us have done or participated or taken webinars before. This is a little bit different. And there'll be glitches, there'll be problems. There's over 400 people registered today. And so we don't know how well that will go as far as if everybody can hear or see the videos or see the presentations. So just be patient and persevere through the glitches. Make sure you ask questions. Like, we're doing this not to make ourselves look good. We're trying to teach people technique and stuff that we love to do. And then try to respond by sending cases on those weeks that we ask for them. And then you'll get email notifications each week about what's coming up and how to register. Like I said, the live event will take place in the fall, and as soon as we know when that will be, we'll get that information out. It'll be a total of 1 day of practical exercises. It'll be a Friday afternoon and a Saturday morning session. So it allows you to only miss 1 day of 1 weekday of work. So you can get both practice on cadavers as well as potentially enjoy Las Vegas Saturday evening. We're going to have a very low participant to faculty ratio. It'll be 2 to 1. We'll have cadaveric osteotomy exercises as well as some practical exercises using synthetic bone planning and osteotomies. And then we'll also have a Saturday night event with the faculty to, potentially start a mentorship relationship or learn more things. So we really encourage you to consider doing that. So just for those of you, I'm sure everybody's done some Zoom meetings over the last couple months, but all of your microphones are muted and videos turned off. That's to help with bandwidth and avoid distractions like your cat or dog barking in the background. Send in your questions through the Q&A component. Don't send them through the chat. The moderator will review questions as they appear and present them to the faculty. And if a lot of them are similar, just like with webinars, if everybody has the same question, we'll answer that variant of question. So just make sure that we try to stick with the questions about the module that we're presenting at this time. We're going to go over a lot of stuff in 10 weeks. So let's get started. And so we're going to jump to module 1. And so I'll be the moderator for this session, which is preoperative evaluation and planning, and Matt Camuso is going to help filter through the questions. And the primary faculty for this module are Mitch Bernstein and Raul Vadia. So these are our disclosure information, which none of them are really that relevant to this. So this was a patient of mine that's a 42-year-old with hypophosphatemic rickets. And she had femur and tibia pain, and you can see that she has bilateral knee arthritis, but she has 5 different stress fractures because of mechanical overloading due to her congenital deformity and how that kind of progressed over time. You can see that she's got tibia stress fractures, femur stress fractures, and a left femoral neck stress fracture. And so how would you evaluate this patient in clinic? What images would you get? And then what deformity planning or evaluation can you do? So at the end of this session, the learner will be able to identify how to correctly evaluate lower extremity deformity and practice digital radiographic evaluation of lower extremity deformity. So this is the outline for this module. So we'll start off with Mitch, who will go over the physical exam, imaging you need, and then how to reliably get it. And then both Raul and Mitch will do understanding deformity, and you'll have, it's really important to really get the effect of this module to have 2 devices. And so that should have been on the link registration. And so if you have your desktop or laptop, if you can also use you could use your phone to listen to the audio and view it, and then either use a tablet or your laptop to be able to do the actual practicing. And then we'll end with a 15-minute Q&A session and kind of wrap it up. So with that, we'll get started with Mitch.
Hello, everyone. All right, thank you very much, Brett. This is a very important lecture, not to be rude to my colleagues, but the most important lecture of the course. So I'll give you an example. I saw a patient a year ago who had knee pain. A lot of us, I'm sure, see patients with knee pain, but I just want to try to stress the cadence of the clinic appointment. So you really got to listen to their symptoms, examine the patient. In this case, the patient had knee pain, obviously a full knee exam, and watch the patella as it tracks, look at them ambulate, and then obviously you're going to get routine knee x-rays. So this patient had patellofemoral maltracking, and not too confusing that he had knee pain. So because of his genu valgum, I ordered a standing hip to ankle x-ray, and he had genu valgum. and indicated him for bilateral osteotomies of his distal femur, but take a look at his patellofemoral joint by just realigning his mechanical axis. So it's very similar to Brett's case. A lot of the deformity patients that we treat are very rewarding, but they do require some time to evaluate them in the clinic, which may be a little bit different than what you're used to if you're not seeing a lot of deformity patients. So at the end of this session, you should be able to really appreciate the slower pace of deformity evaluation. Describe the clinical assessment of rotation in the femur and tibia, and then we'll go over an appropriate method to order x-rays for deformity analysis. So here's another case. This is a retired pediatrician. He's 80 years old, had a total knee, and then broke his tibia. And he came to see me because he had a really bad gait, and he had a big valgus thrust on exam. And when we ordered the hip to ankle x-rays, it was true. He had a big valgus deformity. But then on a closer exam, his tibial components and femoral components were not put in valgus. This is a 90-degree angle, which is appropriate for a knee replacement. We actually sent him back to get the proper x-ray. In this case, it's a knee forward or patella-centered x-ray. And upon reevaluation, he actually had a straight leg, but after they fixed the tibia, it was externally rotated 30 degrees. So he actually had a 30-degree external tibial torsion deformity, which caused his valgus. So if you're new to deformity, I think it's important to really set up your clinic and adjust from the routine. I call it emotional preparation. So, you know, if you're seeing 40 patients a day and you put in some deformity patients, you must appreciate that they take a lot of your time. This is a young nurse who had a very complicated proximal femur fracture and then was sent for deformity evaluation. But really, by listening to her, she told us that she had a rotational component. So in addition to the coronal realignment, we adjusted her internal rotation deformity of her left leg. So again, you know, if you're a trauma surgeon and you're seeing a lot of pilon fractures, you understand there's a certain personality to those fractures, and, you know, compared to diaphyseal lesions, and that compared to limb lengthening patients. So this is a patient who's undergoing humeral lengthening. This patient's seen every week. There's sometimes strut changes. So these appointments can be 20 minutes instead of potentially 5 or 10 minutes. So I think it's really important to adjust according to the pathology. And if you're seeing deformity patients, they do require a lot more of your time. So this old school orthopedics takes time. They should be appropriately disrobed. Even if they come in for an ankle deformity, it really is important to look at their knee joint, look at their hip joint, you know, look at their range of motion, look at their stability, and make sure that you have the time and equipment to do that. So this is an example of a physical exam sheet that I use, and I really mark down, you know, what the rotational profile is and range of motion. Physical exam is really important. I think it's very important to watch them walk in the hallway, not in the exam room. And every time they go back and forth, you're looking at their foot progression angle, which is the sum of the tibia and their femoral rotation, see which way their foot points. You can also look at their patella to see if their patellas, as the knee extends, the patellas rotate in or out or straight. You can look at their pelvis to see if they have any hip hiking gait or any antalgic gait. And that really, this dynamic exam really helps you understand what the magnitude of the deformities are and where the deformities are coming from. This is a patient who had a femur fracture treated non-operatively, and these x-rays show an apparent translational and angular deformity. But what's not apparent is the rotational component of this deformity. So for femur, I do a prone rotational assessment. So this would be the prone exam. This is the vertical. This is the left or non-affected leg, and this would be the external rotation arc. So in that case, this would be about 35 degrees of external rotation. If you look at her right femur, she has basically 90 degrees or more. You know, the bed and her other leg are actually blocking this, but she externally rotates almost to 110 degrees compared to about 30. And if you look at her internal rotation arc, again, the right leg or the affected leg is this, and it's very hard for her just to get even 5 or 10 degrees of internal rotation. So she has an external rotation deformity of her left femur that is quite debilitating. In the tibia, it's important to have the knee joint or the patella as a reference. So this is a patient who has the right tibial malunion. And again, he has an external rotation deformity just by physical exam, by the appearance of his right lower extremity. The 5-foot axis is very good to look at the tibial torsion. It's about 15 degrees, but it's really important to compare it to the other side. And that's really what you want to correct if you're indicating patients for surgeries, returning them back to normal. So this is a patient who's prone. You can see he has external tibial torsion, which is normal on the right, and he has internal rotation on the left. This is a goniometer, and I usually go down the axis of the foot or perpendicular to the malleoli. So that would be, you know, if the medial and lateral malleolus would be like that, I would go perpendicular to that, and that would get the foot axis, and then you want an axis down the thigh. So you have an axis down the thigh, then an axis down the foot, and then you use the goniometer to figure out what that angle would be. This is supine. This is a patient with Blount's, also has a component of internal tibial torsion. As you can see, having the patella facing up, you can see that the tibia is actually internally rotated. So it's a supine exam. And this is a patient who has external tibial torsion as seen on supine exam. In the sagittal plane, this is an example of a 13-year-old. Again, listening to her story, she tells you their foot turns outward and there's a concavity on the proximal aspect of her tibia. She said it's very difficult for her to run. She has a lot of knee pain, and she actually feels like her knee hyperextends or becomes very unstable, is what she says. And she reports that she had a tibia fracture a year ago that was treated in a cast. So if you do your physical exam, that's her normal side. You have a little hyperextension, but on her affected side, she has a significant hyperextension on physical exam. Correlating that with rotation on the right side, she has a little bit of external torsion or increased external deformity as compared to the normal side on the left. And her standing hip to ankle x-rays demonstrate a little bit of genu valgum on the right side, but not significant. But if you look at her sagittal plane, there's an example of a apex posterior deformity in the proximal tibia. So in this case, this would be an example of a very good x-ray. You have the whole tibia on one cassette, it's calibrated, it's good quality, and then from that, you can measure your deformities, which you'll learn about, and then do an osteotomy and have these patients be very satisfied getting them back to normal. So for quantifying limb length discrepancies as a component of deformity, I use physical exam blocks that are calibrated and marked, and I ask the patient what they feel most comfortable with under their foot. That is, for me, one of the most reliable, as in conjunction with the x-ray, very reliable assessment. I stopped palpating the iliac crest. I don't measure from the ASIS to the medial malleolus. I find it very inaccurate. And then, of course, the hip to ankle x-rays. I'm always asked this: how do you practically get reliable imaging? And I think it's a source of frustration for a lot of us. I have to tell you, if you invest time at the beginning, if you meet with the radiology technicians, show them your cases, show them what you want. They are amazing people and very responsive, and they will give you reproducible, high quality images time after time. I've lectured with the radiologists who are super eager and motivated to listen to what we're doing. Establishing a clinic protocol is very important, and then training them that they know if it's you ordering the x-ray, you're going to be sending patients back so that they are motivated to get really, really high quality images. So this is, I just took this last week. This is our radiology suite. This is where the patient would stand. There's Brett. And this is our machine. And the machine actually will stitch the images together. So it'll do an oblique. Oh, that's a little high. Sorry, Brett. It'll do an oblique up to the top and then oblique down to the bottom. And as it sweeps it, it'll stitch the images together. It's very important to calibrate the images. So on the right, that's a calibration marker, 1 inch or 25.4 millimeters. This is an order sheet I took when I was a fellow in New York back in 2012, but it really is critical for ordering images. So the first one is the standing hip to ankle x-ray, and you can see you're telling the tech to have the patellas forward, to be centered on the knees. In that case, it's a little bit older technology. If the patient has a block, what block is under which leg, make sure the pelvis is equalized. Similarly, if you're doing femur x-rays, femurs, you want the whole bone on one cassette, you want them calibrated, and you may ask them to center on one joint or the other. This is a recent case I did. This is an example of very good x-ray. This is calibrated. The whole tibia is on one cassette. They have already oriented the tibia for me. I didn't, for this PowerPoint, I didn't reorient these images. Those techs send them straight out to you, and you can very reliably get good planning and plan your reconstruction after. If you're a surgeon who does a lot of circular fixation, it's very important to tell the tech to center the x-ray beam on the ring that is adjacent to the joint. So this is a patient who has a proximal tibia malunion. He has a proximal 2-ring hexapod. It's very important that the angle on the top ring, so you can see the joint. If you can see the joint, you can draw a joint orientation angle. If you can draw a joint orientation angle, you can measure the deformity. If you can measure the deformity, you can correct it very reliably. The image on the left over here is an example of a very poor image. You cannot see anything. You can't see the joints. You can't measure anything. So this patient would be sent back to X-ray to get a better beam centered on the ring. These are examples of poor X-ray. This is very poor quality stitching. It's very hard to see. Can't see the iliac crest. This patient has a 15-centimeter block, but they never annotated the film that he had a block. So this is an example of poor X-rays. This is an example of very good X-ray. Why? You can see the top of the iliac crest. If you can see the top, you can measure the total limb length discrepancy, including the foot and the pelvis. The patellas are forward. It's calibrated. Once you do that, if you have CAD software, you get very reliable measurements. Then again, you can do your planning all virtually and do your case, and then you can reliably do cases based off your planning. X-ray measurements, again, this is talking about the cadence in the clinic. X-ray measurements for me, I do them when I see the patient. It takes about 15 or 20 minutes. This is an example of just doing manual joint orientation angles. But again, if you're seeing these patients, you really should be blocking out almost an hour of your time, or at least I do, to really get the whole assessment. And then I come up with my problem list and a plan when I'm seeing the patient right in front. I use CAD software, and you get a complete radiologic assessment. So you're seeing these are all joint orientation angles of the proximal femur, proximal tibia, distal tibia. You're looking at the joint line convergence angle, so that's looking at intra-articular deformity. You're looking at the MAD, or the mechanical axis deviation, and then you're getting segment length. So this patient has a limb length discrepancy. It's important to know where it's coming from. So you're looking at the femur, if there's a discrepancy, if the tibia is discrepancy, and what the total discrepancy is. So take home points. This is chapter 1, but a real essential foundation for this exciting course in a career in deformity planning. I think it's very important to take your time in the clinical evaluation to understand the deformity and really only accept high quality images. So I will stop sharing. Thank you very much for that. I'm going to hand it off to Raul.
Screen. Okay, is that working?
Yep, you're good.
Okay, thank you. So I'm Raul Vadia, and I'm going to be talking about malalignment in the coronal plane, measurement and technique. And I've taken a lot of this talk from Dr. Robert Taiji, who's one of my colleagues and a mentor for deformity. And he has a very nice talk on why our legs shape the way they are, which I believe we're going to put on the AO Trauma North America YouTube channel. You can do that for homework. So the objectives of the talk are: what is normal alignment? Is there a deformity and where? And how do I calculate the deformity? And then we're going to do a few examples online and through the Bone Setter app. So the mechanical axis of the normal limb goes from the center of the hip to the center of the knee to the center of the ankle. And it's 3 degrees from vertical in the normal limb. There's a lot of research, physiology, and biomechanics who've shown that. You'll find that in the talk that I've referenced. The mechanical axis and the anatomic axis of the femur are not the same. The anatomic axis is 6 degrees off the vertical from the mechanical axis in normal alignment. And most of the things that we're going to measure, we're going to use the mechanical axis. In normal alignment, the mechanical axis and the anatomic axis of the tibia are the same. So in normal alignment, if you take a mechanical axis, it should go through the hip to the center of the knee to the center of the ankle. In malalignment, if this line goes to the lateral part of the knee, or the lateral part of the knee center, it's a valgus deformity. And if it goes to the medial side or off from the medial side, it's a varus deformity. In normal alignment, the joint line is horizontal. And if it is horizontal, and if you look at this joint line, it's parallel and horizontal, and that's usually in a younger knee where there's no arthritis or any ligamentous instability. Now, if we draw the angles around this from the mechanical axis, and as I said, it's 3 degrees off from the vertical, then the measurements that you would get from the end of the femur or the end of the femoral joint line to the mechanical axis of the femur is 93 degrees. And from the joint line of the tibia, the proximal tibia, and the mechanical axis of the tibia, normal alignment is 87 degrees. If we use the anatomic axis, this then becomes 99 degrees and 81 degrees. Now, this stuff has been worked out for hundreds of years, all the way from Borelli to Powell's to Mackay. And this is a great book that I would recommend that you read, or just watch Dr. Taiji's lecture at the end, which I've referenced. These measurements have been referenced by Jeff Mast in his book, and he referenced them from Dr. Morris Mueller in his book on distal femoral osteotomy. So they're good numbers to remember. Now, when we measure total deformity, we're measuring the mechanical axis from the tibial axis. And as I said, this should be a straight line in normal alignment. In malalignment, it's not. And that's the angle that forms. If we're measuring the alignment of the femur itself, we can measure a line from the distal femur to its mechanical axis. It should be 93 degrees on the medial side. And for the tibia, it's the same thing as I just mentioned, 87 degrees. Now, the normal joint line is usually parallel, but because of cartilage destruction, bone destruction, and ligamentous laxity, this can cause a deformity, but we have to measure. And to understand alignment deformity in the frontal plane only, we must answer these 4 questions. Where is the mechanical axis? Is there a deformity, varus or valgus? What is the total deformity? And is the deformity located in the femur, tibia, or joint? Now, I want you to go and I want you to pull up on your device. Whoops. So let's just go to here. On the internet, I want you to go to learn. I'm just going to bring this down so you can see it. learn.detroitbonesetter.com. And if you go there and you type that in, you should have this screen come up. And what I want you to do is put in your full name or your alias, whichever one you're going to continuously use, as we'll have several exercises with this. And I want you to put in the lesson code RV case 1 and then start, and this lesson should come up. So I'm going to pull that over to the side for a second, and I'm going to quickly go over the rest of this talk and tell you what we're going to do. So we're going to locate the center of the head of the femur, and we're going to locate the center of the talus. We're going to draw a mechanical axis. And again, this is varus. It's medial to the knee joint, the center of the knee. We're going to find the total deformity by drawing an angle between the mechanical axis of the femur and that of the tibia. In this case, it's 13 degrees. We're going to measure the joint line, and it's 3.5 in varus. And then we're going to figure out how to add these things up, because we know that the normal alignment is 93 and 87 degrees. So let's go to Bone Setter, and let's do this together. Now, I want you to let me know if you've all been able to get onto the website and if you're having trouble. So Brett or Matt, could you maybe take a little joint line, see if the people have been able to get onto Bone Setter? And you guys can split your screen. I'm going to keep mine like this, but you can split your screen to left side and right side so that you're on Bone Setter on the right side and you're on Zoom on the left side. And we're going to do this together.
Raul, people are asking for the case or the lesson.
It's RV case 1. I'm going to put that back up for a second. 1 second. Let's just come back over here, and I'm going to put this up again. Let's put that up. Dawn, is that good? Or Matt?
Yeah, that's good.
Okay.
And if for some reason you don't see it when he switches over, it's in the chat section as well.
I'm going to give you a minute to get on. And then I'm going to get off, and I'm going to bring this back over. And I hope you guys are on now. Brett, do you think I should just go ahead?
Yes.
Okay.
Since it's recorded, we can, if they don't get it right away, they can go back and look. But I think we need to kind of, since you have a few, let's start going.
Okay. So there's a few tools that I want to teach you. The first thing is, this is your canvas, and I've put the 4 questions up here. There's a button over here that shows x-rays and a button that shows items. You can put your notes down here, which I put the questions. So let's start by doing a task that is magnified. There's a block over here with a plus sign. I want you to click on that, and then you can drag over the x-ray and you can magnify, so you can work a little bit better. Now, there is a box which looks like it has 4 arrows. You can click on that and it goes right back. So let's do that again. Magnify, and then go back. Now, you guys should all try that and see if you can do it. And next, we're going to start that again. So magnify, look at the hip, and I'm going to show you how we can get a spot in the center of the hip. There's a button here called Hip Center. If you push on Hip Center and then you click on the center of the hip, you'll get a target. You can move the target till you think you're right in the middle of the hip, like that. And then I want you to lock it, which come over to the side, and there's a lock box. Click it, and once it's locked, this won't move. Let's do that again. If you want to get rid of something, you can tap on it and put an X. So let's do Hip Center again. Put the Hip Center on, and then I'm going to lock it. Now, once you've done that, let's draw a mechanical axis. So let's go back to the full screen. Remember, it's this one here, the 4 corners, and we're going to now draw a mechanical axis. We do that by using the line tool. Click on the line tool, And then what you're going to do is click from here and click at the center of the ankle. That has drawn your mechanical axis. Now you can shift that around as I've done. And if you want, you can blow this up and make it perfect. Come back. Blow up the ankle. Make sure you're in the middle. Come back. And now you've got a mechanical axis. And so where is this mechanical axis? It's to the medial part of the center of the knee. So this is going to be a varus deformity. The other thing that this line allows you to do is it allows you to measure the leg length. Because we've calibrated all the x-rays, you can do that with a marker or the sides or the bottom, whatever you're using. The marker, the round ball is actually the best way to do it. And I'll show you how to do that in the tutorial next week. But if you've done that, you can come over to items. Remember, there's x-rays and there's items. And on the items, it'll tell you the exact length. So the next question, once you've all done that, once you give it a try, I'm going to do it again. If you've done something wrong, there's a button over here to go back. I'm going to draw the line again. And I'm going to go to the bottom. And you can see that I can center that. And that's my mechanical axis. The second thing I'm going to show you is now the angle tool. And if I use the angle tool, it's just like a cob angle. You can draw it one thing to the other, and then you can move it. And if you don't like it, you can get rid of it. So let's now figure out what's the total deformity. So we're going to go to angle, and I'm going to draw an angle through the center of the femur, from the center of the hip, through the center of the knee, and then one from the center of the tibia to the center of the knee. And that's going to come up here, and it's going to be 11. I can make it a little more accurate by using the tool that I've described to you, the magnification tool. And again, down at the bottom, there's my magnification tool. Whoops. And just clicking on that and bringing it over. There we go. I think I'm pretty good for the center of my knee. Is there a lot of comments about people wanting me to wait, Brett or Matt?
Sounds like it's going okay. There was a question. Can you just show how to delete the lines or angles again real quick?
Yeah, that's great. So if you click on a ball or you click on an item over here, you can then go to the X and delete. And if you made a mistake, there's an undo button right here. It'll bring it right back. And you can start over. So we see that the deformity here, the total deformity is 12 degrees. Now I'm going to get this out of my way because it's in the way for my next measurement, so I can hide it and then I can bring it back. That's just for that. So now we have a 12-degree varus deformity, and is the deformity located in the femur, the tibia, or the joint? So what we're going to do is draw the mechanical axis of the femur with its distal joint line, and I'm going to take angle and I'm going to draw it from the center through the center of the knee, and then I'm going to look at the distal femur. And let's magnify this a little bit so that I can see it and make it perfect. There we go. And I'll come back up here and I'm going to put that through the center. And the angle here is 86. So what did I say the medial angle was for the femur? Normally it's 93. And normally for the tibia, the medial angle is 87. So I'm going to leave that up there. And if I see this is 86, then my femoral deformity is 93 minus 86, which gives me a deformity about 7 degrees. And it might be 8. Might have to move it a little bit closer. I think it's turned out to be, yeah, about 7.5. We're going to go back, and now we're going to do the same thing for the tibia. We're going to draw a line along the joint surface, one down into the tibia along the mechanical axis. And again, I'm going to adjust it by doing a little bit of magnification and drawing it right along the joint line there. And I think my center is a little bit more this way. And let's go down to the center of the joint line on the talus. I'm there. And the angle that I've got coming up here is 84.5. So 87 minus 84.5 is 2.5. And the last thing I'm going to do is I'm going to measure the angle of the joint line, and I can use the two that I've measured already from here, and I can go over them, and the angle there is about 3. So if I add this up, I've got about 7 degrees deformity in the femur, 3 in the joint. And again, it looks like there's a little bit of arthritis and a little bit of ligamentous laxity. That's why that joint line's not flat. And I've got about 2.5 degrees in my tibia, or about 12.5 or 12 degrees for the total deformity. And I've put that stuff in there. What I want you to do after you've done that is I want you to go to File, and I want you to save. If you want to keep this exercise on your laptop or your device, you can also go to Export and save as JPEG or PNG and put in whatever name you want. It'll go right on to your desktop. There it is, and that'll save it for you. Now, if you want me to repeat that, please chat in that you want me to repeat that. And if you've got it, then that's a good thing. How's that look, Brett? And
looks good. There, nobody's typed a question since you asked, but we can wait a few seconds to see if anybody. There's been some specific questions about not being able to move the center of the ankle, but just to make sure that they don't have it locked. And then actually just one came in. Can you go over the joint line angle again?
Yes, how to measure the joint line?
Yeah.
Okay, let me get rid of all these ones. And what I would do is I would go to angle, and I would go to the distal femur, and then I would go to the tibia, and I'd make it as close as I could to what it was. You can see it's a little bit opening on the lateral side, and you've got loss of cartilage on the medial side. And if you do that, it almost looks like 3 or 4 degrees. How's that? Now, if you did save it, I'm going to go see if anybody has saved it. Let's see.
They are saying that how quickly you're going through it is about right. So great job.
Okay, so I'm just going to pick a project that someone did. There you go. This is Daniel Miles, and really good drawings here. Daniel, I might just move your angle of your joint a little bit like that. Otherwise, not bad. This is through your center of your hip looks decent, and your talus point looks good. Your leg length is about just exactly what I got. Femur line is good too. Very good. If you put in your deformity measurements here, we can check those too, but very good. I'm going to have another look. Sean, Good job, Sean LaRue there. Yeah, those look pretty good. Nice work, you guys. That's looking very good. And I'll get you some feedback on this one. And what we're going to do now is, would you like to try? Would you like
quickly just do leg length real quick?
Oh, yes, absolutely. So leg length, let's go over here. So you've got a couple of choices for leg length. And as Mitch said, you know, you got to make sure, first of all, to have a good x-ray in both sides. And then you can either do it from the ground, from the ankle, if you assume there's no deformity in the foot. And if you're doing it, you can also do it from the center of the hip or from the top of the acetabulum, top of the pelvis, if you think there's a pelvic deformity, but you just have to use the same on both sides. And then when you go to the items section, it'll come up, because I've calibrated the x-ray, it'll tell you the exact distance. So that's how you would do the leg length on one side, and you can compare it to the other side, which we'll do in a sec. So should we go to the second one?
Yes, I think that's a good idea.
Okay, so what we're going to do after you save it and export it, I'm going to reload the page, and I'm going to do the same thing. Then I'm going to go to RV case 2. And this is what should come up. And now what I'd like you guys to do here is I'd like you to do both sides. And you go ahead and work at it, and I will do it at the same time. And if you're having an issue, please put it on the chat, and I'll revise it. So I'm going to do exactly what I did for the first side. Now we have both sides. So you can actually compare right to left side for leg length and stuff like that. And Mitch, if you have any pointers for how you do this, I think we've tried to keep the kneecap straight. And I think we've got a fairly decent x-ray, and we've got your marker in the middle there. This is a case that walked into my office about a year ago. But
Raul, can you quickly just show how you loaded the second case? There were some questions about that.
Okay, so let's go back, reload site. Now, all you have to do is reload site. If you push that reload button there on the top left, the one that looks like an arrow with a point, and then you can put your name in, and again, RV case 2. There you go. Good, Brett. Do you think I should start?
Yes.
Okay, so let's start again with a little magnification. And let's start putting in our hip center. So let's start with the hip center. I'm going to put a hip center on this side. And I didn't show you this the first time because I thought it was a little too much, but you can change the size of the hip center over here with these arrows here. And then I'm going to lock this one in. And I'm going to go to the other side, and I'm going to put the hip center over here. And I'm going to lock that one in. And then let's focus on the good side. I'm going to draw a line, so go to line, and I'm going to put it right in the middle there. And then I'm going to scroll down and put it in the middle of the ankle. And as you can see, this is just slightly to the middle of the midline or the center of the knee. So it may be very slight varus, but probably pretty normal. And then what I'm going to do is I'm going to focus on this side because we know the other side's pretty good. So I'm going to draw a line again. And I'm going to draw it all the way down to the bottom. And then if I wanted to compare leg lengths again, I think, you know, depending on how you do it, you could do the top of the acetabulum, top of the pelvis, but I don't think there's a pelvis deformity here. And I think the feet are pretty flat. So the leg lengths that are coming up here in my items, one is 87.10, 83.58. So 87.10 minus 83.58. And that equals 3.1, 3.52. Hope that looks right. My math might be a little off. You can correct my math, but that seems to be right. And then let's go back again to get out of the magnify mode. And I'm going to first do the total deformity, which is an angle through the center of the knee joint and one through the angle of through the mechanical axis of the tibia. And again, I think I'm going to check it. And it looks like this could come a little bit over. And let's see, I'm pretty a bit off the center, so I can make that in the center and come down to the bottom. I think that's pretty good. And that comes out as 15.7 degrees, and it is varus. If you look at this, this does look varus. So I'm going to put over here that that's a varus deformity, and that the total deformity for me was 15.75 degrees. And now I'm going to look at the femoral deformity. So I'm going to hide this one. And I'm going to draw another angle from the center of the femoral head through the knee joint and one across the femoral condyles. And I think this one for sure you're going to have to magnify it to get it right. So there you go, right there and right there. I think that's a pretty good estimation of the middle of the knee joint. And I'm going to bring that right back into the middle of the femoral head. And then my angle over here is 79. So I'm just going to, it's a 79.81, 79.8. And so remember, what is this supposed to be? It's supposed to be 93. So let's come over here, and the femoral deformity is 93 minus 79.81, and that's 13.19 equals 13.19. If I get my math wrong, you guys are going to correct me, okay? So you can send that in on chat. And then what I'm going to do is I'm going to do the same thing for my tibia. And the angle that I got for my tibia here is up here, 85.42. And remember, the tibia is supposed to be 87 on the medial side. I'm going to write that in for you again. The medial side is 87. And so the tibial deformity is 87 minus 85.4. So that's going to be 2.5. And then I'm going to measure the joint line. So let's hide that. Let's hide this. And my joint line, although it looks not too bad, it is a little off. She does have a little bit of arthritis in her medial joint line there, a little bit opening on the other side. And it gives me an angle of about 2 degrees. So what I've come up with here is a total deformity of about 16 degrees, and about 13 is in the femur, 2 is in the joint, and 2.5 is in the tibia. The majority of the deformity, of course, is in the femur, as this is a gunshot wound and someone who's had this malunited fracture for a long time. Now, after you guys are done this one, please do the same thing. Please save it. So again, File, Save. And again, you can export it to your own laptop so you can save and see how you did. And
can you just quickly explain the export? Somebody asked how you export it to like what format you can do. You can do JPEG, obviously, but is there any other?
yeah, you can do PNG or JPEG. So when you come down here to File and you go to Export, it gives you an option of PNG or JPEG. And then watch, if I do it again, I'll go to PNG. It'll just put, you can put whatever name you want on it. I'm going to call it RV Case 2, save it, and that'll come on your desktop and you can look at it later for how you did. And if you save it, I'll be able to look at it and see how you did. And now I'm gonna put all my lines in, take them off the hide so I can see everything. And so what I've come up with is about a 3.5 centimeter leg length discrepancy, about a 16-degree total deformity, mostly in the femur, slightly in the joint line, and the tibia may be very small. and but probably mostly in the femur. The other thing you can do is you can measure the other side and you can compare it exactly. Because this is a fracture, you may want to just take the measurement from the other femur and leave the tibia and joint line alone if you're going to do some kind of osteotomy. So this is a bigger discussion, but that's something that'll come up in the rest of the course. So let's see how you guys did again. I'm going to go to my bone setter app and project and RV case 2 load. And wow, there's Nick Bowles over there, Nick. There you go. Nice job, Nick. And whole pile Ryan. The Ryan's looks good too. Very good, Ryan. Good job, you guys. Really quite a good result. Now, I would tell you, Kevin, also very good. I would tell you that there are 5 cases. So you can go to RV case 1, case 2, case 3, case 4, case 5. We've done 2 of them, and they don't get progressively harder, but there's a different deformity in each one. And this one obviously was a femoral deformity with a leg length discrepancy. The other ones are going to be other things, and you can work those out on this exercise. And that's it. Anything else, Brett?
No, I think there are some critics of your math, but that's about it. So why don't we go ahead and move on to Mitch's.
So I said good at the angles. Maybe you could criticize my math. Sorry about that.
That was excellent. Thanks, Raul. Why don't we go ahead and move on to Mitch's rotational.
Okay, I'm going to stop sharing and go, Mitch. Thank you.
All right, thank you, Raul. That was very exciting. I got very excited as you started talking about the planning part of osteotomies. I don't want to contradict myself, but this is the most important lecture of the course. This is rotation. There'll be a little bit more math, so don't get mad at me, please. And at the end of this session, I'll try to impart to you the relevance of rotational assessment, why it's important, and what kind of disabilities patients can have. We're going to go over the Bone Setter app with a case. There'll be some homework to measure deformity. We can go look at that next Thursday. And we'll go over today some CT calculations on femoral and tibial version studies. So for me, rotation, I think, is the hidden deformity, or maybe the last of the deformities that has been evaluated, researched, published. You know, AP sagittal plane deformities are well described. They're easier to see. I think they're a little bit more apparent. And just don't forget, don't be mean to rotation. It's still one of the components of deformity as one of the 6 planes. It's an axial angulation, rotation. So clinical context, these are some outcome scores on a patient who has miserable malalignment. And you can see here, this is a patient in their clinical outcome score is quite disabled. 100 is normal. In their sports function, 14. So these patients are not doing any sports. She has 8 score as opposed to 100, which is normal, and comfort of pain. And global function 46. Down here, this is another objective score. 88 is almost complete functional limitation. So these patients are quite disabled, and this is all rotational deformity. So that's an idiopathic case, you know, femoral and tibial rotational deformities. And post reconstruction of trauma or tumor, it could be important, as there could be large segmental defects or comminution. So this is another example in our gait lab at the Shriners Hospital. This is a patient who has no sagittal, no coronal deformity, all rotation. So she has persistent femoral aneversion and external tibial torsion. And you can see her gait. She has a valgus thrust. Her pelvis tilt. This is all from excessive rotational deformities. This is very debilitating for patients. And if you don't examine them, you may, in my experience, you may say that there's actually nothing wrong with them, because if you get a hip to ankle x-ray, they most often have very, very nice coronal alignment. This is an example of a similar patient, and you can look at their patella, and you can look at their tibial tubercle, and you see the vectors of the pull as the femoral condyles are internally rotated, and the tibial tubercle vector with the patella is externally rotated. The patella becomes very not balanced, or very imbalanced, I should say. So this patient underwent a diaphyseal rotational correction and a supratubercle rotational correction to correct the TTTG as well as the tibial torsion. So how do you assess rotation? We talked about that already. That's the prone exam with the femur and the tibia, and then CT version studies are also important. So I get CT rotation studies to confirm a clinical suspicion. For post-trauma reconstruction, if you want to get a baseline of what the other side should be and how much you need to correct. And we do CT cuts through the neck, femoral neck, the femoral condyles, and the proximal tibia and the ankle joints. I think still to this day, the interpretation should be done by you and should not necessarily rely on the radiologist's interpretation alone, unless your radiologists are very good at reading these studies. Recently, I've been working with our radiologist, and I was actually quite surprised that they do not know how to read these studies. So we've been working on how to read them properly. You can read it once by yourself and then come back and make sure you did it correctly, or you can just speak to a friend and they can look at it with you. So this is an example of femoral version CT. You find the best fit cut through the femoral neck. I do a line through the femoral neck and then a horizontal to figure out what the rotation is, and same with the femoral condyles, a line on the posterior aspect of the femoral condyle. If you do these a lot, your X-ray techs or Raoul's, I think a bone setter, you can actually overlay them and do your calculations that way. In the tibia, I use the femoral condyles as a surrogate of the proximal tibia, and then at the level of the syndesmosis, I'll do a line perpendicular to the incisura. So I'll draw a line here, and then an orthogonal line or a best fit line across across the tibia, and then that Cobb angle relative to that will give you your angle. So how do you do the math? This is basically what we get paid for. This is figuring out, does the patient have too much anteversion or too much retroversion? So the math is very important. So here's a patient, it's the right lower extremity. You see on the top is cuts through the femoral neck, and you could say that the femoral neck is externally rotated 30.87 degrees. At the level of the knee joint, you can say that the femoral condyles are internally rotated by 28.24 degrees. Up to this point, I have not said anything of value. You can argue my whole talk is anything of value, but I just said nothing of value yet. What you have to do, and this is the way I do it, is rotate. Rotate the femoral condyles so they're flat. In this case, I would have to externally rotate the femoral condyles 28 degrees. Because the femur, the femoral neck cut, is already externally rotated, you're going to increase the external rotation of the femoral neck cut by that same amount, 28 degrees. So in this case, you would add 28 plus 30, that would be 58 degrees. If you look at this CT scan with the femoral neck flat, and if you look at the femoral neck pointing that way, that's anteversion. So this patient has 58 degrees of femoral anteversion. That is abnormal. We think normal anteversion is about 10 to 15 degrees, but that's also potentially, I mean, there's obviously a range for that. So here's the tibia, the same thing. You have an angle measurement on the femoral condyles, an angle measurement on the ankle joint. So on the knee exam, this patient has 26 degrees of internal rotation. The ankle is 7 degrees of internal rotation. Again, I have not said anything of value yet. What, at least for me, what I have to do, I have to make the femoral condyles flat for this thing to work. So I'll externally rotate the femoral condyles 26 degrees. In the process, I'll have to externally rotate the tibia 26 degrees. Because the tibia was internally rotated, you're going to lose some of that rotation. So the net in this case would be 19, or you'd minus 26 minus 7 is 19. Please check my math, so you don't have to because I have a calculator. And then again, if you look at the femoral condyles flat, and if your right leg is pointing externally rotated, it's a little bit easier to say this patient has 19 degrees of external tibial torsion. So here's a clinical example. This is a 41-year-old who had an open distal femur fracture, 13 centimeters of bone loss. Not too exciting. But for me, I'm pretty sure that I did not get the axial rotation correct. So what I did is I ordered a CT scan after the case. Okay, so again, in this case, the femoral neck cut is 0 on the right side. The distal femur is 16 degrees externally rotated. So on this right side, the patient has 16 of external and 0 of external. On her normal side, she has 12 degrees of internal rotation at the level of the femoral neck and 15 of internal rotation at the femoral condyle. So again, very confusing to this point. You just have to make the condyles flat for this to make sense. So as you're going to make this flat, you'd have to internally rotate the femoral condyle 16 degrees. As you do that, you're going to bring the femoral neck down to this location. So that would be a retroversion. Okay, and on the left side, you'd have to externally rotate to bring the femoral condyles flat. In the meantime, you're going to have to minus because you're already 12 degrees internally rotated. So you bring this up, so you'd have 3 degrees pointing up. So what you would say in conclusion, this patient has 3 degrees of anteversion on the left side, and I caused this patient to have a retroverted femur of 14 degrees. In conclusion, part 2, the patient has 14 plus 3, 17 degree deformity. Or I would have to internally rotate the distal segment 17 degrees to fix the problem. So this is a Masquelade technique. I took off the proximal screws. I set up Steinman pins at the beginning. I internally rotated the distal segment 17 degrees and used a goniometer, which is a bit sad, but that's the technology that we have today, and fixed her rotational component. So rotation is a component of alignment. Look for it on all your deformity cases, measure it clinically. You can look at the CT version study, and it should be interpreted by you and speak to a friend as needed. So I'm going to show the bone setter case. I'm going to just pull that up. Any issues, Brett, or anything?
Just maybe while you're doing that, and maybe explain on the, if you can, with the bone setter part, just people are having a little bit of trouble understanding like the rotating the bone standpoint. Can you just give a quick sum of how to do it, just if between positive and negative, or anti-torsion versus retrotorsion if you don't rotate it? Maybe my question, does that make sense?
Yeah, I mean, if you, okay, so let me pull that up here. So I'm gonna go into, you guys can pull up MB case 1. So Mitchell Burns is my name, MB case 1. MB case 1. So I'll just wait a second. So that's still, you know, I do a lot of these CT studies, and that's the way it makes sense for me. If you don't do it, I heard Raul explain to his group, I don't know if Raul, you want to comment on the fish mouth thing, so I could show that here. So I assume everyone is up into MB case 1. So I'm going to draw a line down the femoral neck, and I'm going to draw a line down the femoral condyles. Okay, so this would be a 27.24 degree. That's the answer. But you need to figure out, is this anteverted or retroverted, or antetorsion or retrotorsion? So in my head, the way I do it, I have to get the femoral condyles flat for me to understand, because I know the anteversion is when the femoral condyles are, when the proximal femur is externally rotated. So what I would do is rotate the femoral condyles flat. As you rotate that flat, this becomes externally rotated. Rule, do you want to comment on the fish mouth analogy?
Okay. Here, do you want me to go to Bonesetter and just draw it on there, on yours?
Yeah. So
Okay.
I'll stop share and you can.
Okay, I'll share and I'll go on. And one sec. I'm going to get out of this and I'm going to go to yours. Whoops, right here.
I think that the positive and negative, Brett, I don't use it, but I guess you could, I mean, you really have to trust what I'm saying, but you definitely have to verify it as a user. So
I think the point, or like I do it a little bit differently just because of the system that we use, is that if they're pointing the same way, it's usually a subtraction problem. If the femur's pointing anteriorly and the condyles are pointing or rotating inward or internal rotation, then it's an addition problem, right? So you're adding them together to get the deformity, just like you did with your anti-torsion example. But if both of them are externally rotated, then it's subtracting to get the actual difference. I think that hopefully that may help, but I think just because not everybody is going to be able to rotate the images in their system when they have a fixed system like most of the PAC systems are, I think it's just a little bit more challenging to actually rotate them. Does that make sense?
yes, 100%. Our new PACs from last year had that feature, but I agree, most PACs you can't rotate the images, but that's what I do in my head. And I have to say, by speaking with the radiologist or the residents, everyone does it their own way. And I think you really have to find something that is reproducible, that gets you to the answer. My way is not the right way. It's obviously one way, and these lend itself to different methods of interpreting it.
One of the participants said they just turned their head.
So I use this fish mouth thing. So the fish mouth always opens up to the butt. There's the butt. If the fish mouth is biting the butt, it's anteverted. And if the fish mouth is away from the butt, it's retroverted. Okay.
Nice. Okay, so I can show MB case 2, Raul. So I'll go back, if you stop sharing, we're going to be back in MB case 1. So this would be a line in the femoral neck. Here's your line on the posterior aspect of the femoral condyles. You have an angle of 27 degrees. So this patient would have 27 degrees of anteversion. And the fish mouth opens to the right. So that's anteversion. If you're doing tibial torsion, again, I recycle this line. I use the proximal femur, and then I put a line of best fit or the perpendicular to the incisura. For me, the way I do it, you know, is even now it's very confusing for me. So what I do, I break it down to femoral condyle flat line, and then I do them separate, usually because they're not overlaid. I do it like that. So then I write down that the femur is 18 degrees internally rotated at the femur. The tibia is 27 degrees externally rotated at the ankle. Put this knee. Okay, and then the math, we got to figure out the math is obviously the most important. So for me, what I have to do is I want to make the femoral condyles flat for this to make sense. Otherwise, my brain is like on fire. So I'd have to externally rotate the femoral condyles to make them flat. Because this is already externally rotated, I'd have to increase it. So I do 18 plus 27. Use my calculator here. 18. Which is 18 plus.
It's 45.
I'm not a millennial, but I'm pretty close. 45 degrees. Okay. So this patient has 45 degrees of external tibial torsion. Let me just go into MB case 2 quickly. MB case 2.
Mitch, can you again kind of reiterate why you're using the condyles instead of the proximal tibia, since you may not get it exactly perfect?
Okay.
By doing
Very,
it that
very
way?
good question. Very good question. Number one, I'm not right. I am not necessarily right in doing that. There are patients who have intra-articular rotational instability that you should not do that. For me, I find it's more reliable to get a cut or to draw my line across the posterior condyles. There are published different techniques that do use the proximal tibia. So that's just my preference. It's not necessarily better. I just do it because I like drawing that line.
I think if we can, or I was going to say, if we could kind of move through this one, then we're getting close to 90 minutes. So I just want to make sure we get some questions answered.
So I'll stop after this. This is the reversed fish mouth according to Raoul. So this patient has a fish mouth that way, if you want to use Raoul's method, of 13 degrees. So this patient actually has 13 degrees of retroversion. If you wanted to do it the other way, I would do an angle here, an angle reference, and then I do an angle across the posterior femoral condyles, and then a flat reference, and then you got to do the math. So at the femur, it's 11 degrees internally rotated. At the knee, it's 26 internally rotated, and you're going to minus them because I'm going to have to take the femoral condyles and make them flat. So I'd have to externally rotate 26 degrees. Did I do the wrong? Where's, oh yeah, blue, sorry. Blue is 26. This is really embarrassing. I'm sorry, guys. 11. Oh boy. Oh boy. Oh boy.
Mitch, where's your
Sweating.
kid?
My kids are outside. I'm sweating. I'm sweating right now. Okay.
It's good that this isn't being recorded or anything.
Okay, so here, yeah, here we go. You recovered. So externally rotate the knee 11. You already have 26 at the femur, so it'd be 26 minus 11. Let me get my calculator. 26 minus 11, 15 degrees. Retro, because the femoral neck will still have residual internal rotation. Okay. What do we got, Brett?
We're going to wrapping it up. Just keep coming in with your questions. And getting to the end, sorry. So some of the questions that people had, we'll get to for sure. Can everybody see my screen okay?
Yep.
Okay. So as you guys have gone through this, and thanks for staying on, Mitch went over the physical exam and imaging needed and then how to get it. And then both Raul and Mitch went over the Bone Setter app, which is very helpful. And a lot of you had questions about how to get that. And I put the address, the web address in the question and answer section.
I think it's just still on my, I think it might be on the other screen like you had before.
Can you see it now?
Now, yeah.
Yeah, sorry. And so we have about 15 minutes for questions. We'll probably cut that a little bit short since we're over. But some of the questions, thanks for those that sent them in. But one question I think that was really good is, what do you do if you have a patient with a knee flexion contracture when you're trying to get the imaging, like especially the extremity alignment series?
So did you address it to Raul? Can I answer that, Brett?
Go ahead, Mitch.
So it's illegal to get a AP standing hip to ankle X-ray in a patient who has a flexion contracture. So what I would do is use lateral images to assess the limb length discrepancy. So you'll probably have to speak to your X-ray techs because they may not be used to it, but they can get a lateral version of the hip to ankle X-ray and then measure the segments on the lateral. That's a great question. It's also why, you should never send a patient with a large limb length discrepancy for an AP X-ray without their limbs equalized on a block, because they may flex the contralateral limb.
That's a great point. And then somebody else asked how to, and we'll address this in later modules, but how do you evaluate the sagittal plane? Just a quick kind of
if there's
way you do it.
There's a contracture or not a contracture?
Just in general, how do you evaluate the sagittal plane?
If there's no contracture, a lateral X-ray of both bones is decent, or even a standing lateral. But like I said, the biggest problem with the sagittal is what you just mentioned. If there's a hip, knee, or plantar flexion deformity of the ankle, that's where you get into trouble. And
for bone, there are sagittal joint orientation angles. So there is a sagittal mechanical axis of the femur and tibia. There are sagittal normal values. So it's very similar to the AP. We didn't go over it for time, but yes, it'd be very similar to what Raul did, but for the sagittal plane. You draw joint orientation lines, mechanical anatomic axes, and there are known normals, joint orientation angles for the sagittal plane.
I think what would be helpful, because there are a number of questions about what's considered abnormal and what's normal. So maybe on Thursday, if we could at the beginning of the session have those references. I know it's a range, but people asked about what's normal for thigh foot angle, what's normal for the rotational profile. So maybe for Thursday, if we could have that information and even the articles that we all reference when we're doing that. And then another question was, do you guys use CT scanograms at all?
So that's a good question. A CT scanogram is not as good as a full-length standing X-ray, but it's really good for your rotation. And we sometimes use it for femoral fractures after we fix them when patients can't stand. And then you do it with a lateral X-ray. You have to make both legs the same angles. But the best X-ray, if you have it, is really the standing upright X-ray. Do you agree, Mitch?
I agree. I don't use CT scanograms. I only use it, like you said, for limb length discrepancies in patients who can't stand, so acute trauma. We have the ability to get standing hip to ankles. They're standing, so you get the ability to look at any instability if there is any. I don't have experience with CT scanograms. Otherwise, I don't use them.
We just use them for when they can't stand up. But for rotation, they're good for the axial cuts. That's really the major component of that.
To be clear, I call the CT scanogram a CT scout image, and I call a CT to assess rotation CT lower extremities for rotational assessment. Otherwise, they're going to, I try to be very obnoxious with the order. Otherwise, they're going to CT the whole extremity. And
so So we've actually, so we talked to, like at our place, we'll call it a CT scanogram, and they'll just do the axial cuts at the joints and minimize the cuts. And then they'll do the scan, like you said, the scan portion for marking as your length measurement. So if we order a CT scanogram, they'll do both.
And then real quickly, do you, when you're looking at measurements and comparing, do you use the patient's other side as a reference or go with what you consider the standards?
Mitch, do you want to get that or you want me to get it?
I don't use the standards. The standards, you know, Raul mentioned 87. I think it's a little confusing. Well, I don't use it. I go to the other side. I go to the other side and I try to match that. And then if you're doing osteotomies around the knee and the patients have pain, you're maybe going to then plan according to a compartment or tibial spine in the knee, which those angles are not as relevant.
Yeah, if you have a normal limb on the other side, go with a normal limb. When you start getting like arthritis and stuff like that, where you really can't tell, then then I think you can use those angles. That's a lot of people use those for like osteotomies for arthritis, and you know, most people who we reconstruct trauma for, we're lucky we have the other limb.
And then just really quick, a couple people asked about the adding or subtracting, and maybe Mitch, you answered it with your fish mouth, and Raul, the fish mouth thing, but basically if they're pointing the same way, which Mitch demonstrated in the last example that he used, if they're pointing the same way, the larger value is going to be subtracted from the lesser value as far as determining if it's the same way it's rotating. But if they're opposite, so the femur is pointing external, the distal femur is pointing internal, then it's additive. And so hopefully that clarifies it. If not, I mean, we'll definitely try to reiterate that on Thursday. There's also questions about using bone blocks or the wood blocks to correct leg lengths, and like was mentioned, you definitely want to. So I think with that, we'll kind of end the question and answer session.
Can I make one more comment, Brett?
Sure.
In my experience, just regarding the contracture, even a 10-degree hip flexion contracture can affect your accuracy of your AP hip to ankle X-ray.
For sure. I think that's why you have to take all of this together. So it's a clinical exam, it's radiographic evaluation, it's CT scan, it's all of this is gathering information to make the correct decision as far as what way to correct it and what way to maybe change how you're evaluating it. So it's adding everything together. You don't just look at the imaging and not look at the patient. You have to watch them walk, just like Mitch showed. So basically, we've gone over this is just kind of the first session of the remaining 9 more to go over how to do it, and then go over specific from the proximal femur all the way down to the distal tibia. So please come back and join us. We appreciate everybody hanging on for going over, but basically you learned about coronal plane evaluation, how you get rotational evaluation, specific bone evaluation as far as the anatomical deformity along the anatomical axes. So just remember that the physical exam will give clues, like the video that Mitch showed with the young girl walking on in the gait lab is super helpful. Like you could see what problem she had just by how she was walking. And then getting the exact imaging that you need is critical. And so make sure that the patella are pointing straight forward. And I appreciate, you know, Mitch putting my head on the screen there. That was hilarious. So thank you. And then look at all of the planes for deformity. Like get the extremity alignment series with the wood blocks to make sure it's right, to account for the leg length difference. Make sure that their joints are normal as possible when they're getting those x-rays. But if they can't do it, you just have to incorporate that into your evaluation. And then practice. You have the links to the Bone Setter app should have been in the registration, as well as we showed you here during the session. So just remember that the recording will be available tomorrow, and you should get a link to that. Or you can just go to the AO Trauma North America YouTube page. And it will take you, usually to just the AO North America page, and then you have to look for the AO Trauma North America. So just make sure you're looking on the right page, and then you should be able to find the recorded session. Join us Thursday for Meet the Experts. So keep thinking about questions that you have, practice on the Bone Setter app in the meantime, and then that'll be Thursday at 8 p.m. Eastern, and you should have a registration link for that as well. The next Saturday will be Module 2, and that's pre-op planning continued. We're going to have Ryuichiro Kafuri show an alternative planning software, and then Raul is going to go over Bone Setter app refresher, just a quick one, just to kind of get people on board for the practical of doing planning and intertrochanteric osteotomy with Raul, and then Keith Mayo. So just remember that it's a 10-week session. You'll keep getting emails about it. And we really appreciate you guys showing up with everything that's going on in everybody's lives. So thank you so much, and we'll see you on Thursday.